All right, so it can't believe it's the end of another academic year. This is going to be, next few days are going to be a celebration of our program and of course, our chief residents who are graduating, a really exciting time. It's a whirlwind for the chiefs. You got too many things to do in terms of getting ready for fellowship, moving out, most importantly, studying for your boards, which will be here very soon. But no pressure. So before we, at the end of every year, thanks to Dr. Frank Shen, who endowed this graduation time and research day, it allows an opportunity for our residents to present their research projects from the year. And of course, there's a cash award determined by the judges, and the judges are myself, Dr. Shen, Dr. Yarbrough, Dr. Brown, Dr. Werner, and Dr. Giduk. So many of us will be judging your projects. Of course, there's a fairly sizable cash award, which will be announced at graduation on Saturday. But again, I want to let Dr. Shen discuss why he created this research day and developed this endowment in honor of his parents, who were educators, as a way to support our graduation festivities and support resident research in perpetuity. So, Dr. Shen.
Thanks, Dr. Chhabra. This is a big day for our other chiefs and the beginning of when they start their graduation before they head off to their fellowships and then eventually off to doing what they want to do. But it's exciting too for the new interns who are, eager and nervous. And it's also nice for us to see each year graduate and see as you guys gain more experience, more confidence, right, as you guys head off. This day, it's kind of surprising. I'm reminded every day when David Craig sends out the email each year that we had this for, I think this is the 9th year or something like that. To imagine that only 10 years ago, we didn't have a research day. And so I've been in practice something like 20 years. So for half of my practice, we were all doing great research here, but we really weren't showcasing it to each other. We're going out to national meetings, but not to each other. And Dr. Chhabra had this vision to start the research day back up here. He and I are part of a group of residents who did time in the lab. We did research here and did research in the lab, Dr. Lee as well. And so it was really important to sort of showcase that. So his excitement about it sort of resonated with me. And so that's why we had this endowment started that allowed us to support that. As far as the ground rules for this, I think it's important for you guys to do research during residency, even if you don't go into academics, because it really teaches you how to read papers, how to understand studies. And more importantly, it's a chance for you guys to practice your speeches before you go out to your meetings. So the judges here will be looking at a couple of things that we think is important in general when you do research: innovation and its applicability. And a lot of times what gets published out there may or may not be important, but it's important for you guys to think about that. So as you're thinking about your studies, and Wendy's really good now about looking back and seeing, is this study being done before? So you guys can look forward and say, is this a question that needs to be answered? So that's really important. You want to have some impact and relevance to it as well. So those two are kind of tied together. And the impact may not always show itself to 10 or 15 or 20 years later. And so I think being thoughtful about those goes a long way to starting sort of what your questions are going to be. Then you really got to design your project well. So I think we'll be looking at that as far as did you think about how to design the study well for what you're trying to answer, the question you're trying to answer, and then the results are the results. But did you capture it, and how did you tabulate it, and then your conclusion? What I used to tell my residents and research residents in the lab is the results are the results, right? It's sort of clear cut in that regards, but it's your interpretation of the results, right or wrong. So you really have to put that together. And then lastly, it's a presentation. So your ability to really cohesively put that together and present it. I think these will be timed. So Winston, it's at 7 minutes or something like that, 6 minutes. And we'll do it in batches by years. And then there'll be, we'll save all our questions to the end, and then we'll go on to the next year. We do half of them this year, this on Wednesday, and then the other half on Friday. Okay. I'm excited to hear the research project. So congratulations to this group of residents finishing up this year.
We'll start at 7, right? Who's first? Katie?
You do want 2 year.
Okay, you ready to roll? We'll start at 7. Got a couple. Judges, David sent out an app to do your scoring, so we should have that. Tight rooms. Oh, yeah. Oh, good. It might be on. Start here.
All right.
We got
6:59.
So we're starting at 7 o'clock, since we've done the introductions and Dr. Chen has explained the ground rules, so it's 7-minute presentations, right? 6-minute presentations and then a turnover. So stay on time or you'll be pulled off. Oh, yeah. 78.
All right. All right. So good morning, everyone. My talk is called Gender Affirming Hormone Therapy Does Not Increase Complication Risk for Operatively Treated Ankle Fractures. I have no disclosures here. So basic introduction. So gender identity and gender expression are under-researched and oftentimes poorly understood aspects of healthcare. And despite work globally to optimize care of transgender patients, the field of orthopedics in particular lacks a robust knowledge of unique healthcare challenges faced by this patient population, particularly in regards to the effects of hormone therapy on fracture care. Gender-affirming hormone therapy is a key part of medical treatment for many transgender patients, and it's of relevance to orthopedic surgeons because it is involved with estrogen and testosterone, which hormones have known effects on bone physiology and metabolism. Despite this established relationship between estrogen, testosterone, and bone health, no studies to date have investigated the effects of gender-affirming hormone therapy on complications following fracture surgery. Therefore, the purpose of this study is to examine the effects of GAHT, or gender-affirming hormone therapy, on fracture healing and perioperative outcomes in ankle fractures. So to do so, we conducted a retrospective review using the Pearl Diver database and identified patients with operatively treated ankle fractures. Inclusion criteria included patients who were between ages of 18 and 59, and those who were taking either estrogen or testosterone consistent with a GAHT regimen within 1 year of an operatively treated and fixed ankle fracture. And this was based on estrogen and testosterone was based on their respective birth assigned sex. And then 90-day outcomes post-surgery were collected, including non-union, wound complication, implant complication, infection, and reoperation. And then we also collected major medical complications and minor medical complications. Major medical complications included MI, PE, pneumonia, and sepsis. And minor medical complications included AKI, need for transfusion, urinary tract infection, and DVT. So patients were then stratified into 2 groups based on their birth assigned sex and a documented prescription for either testosterone or estrogen hormone therapy. And the 2 groups included birth assigned sex men taking testosterone, which is referred to here as the base group, and birth assigned sex women taking testosterone, which is the BAST group. And then regional and annual trends were calculated. So as far as results on 90-day complications, for the base group, which is birth assigned sex men taking estrogen, there were 350 patients who are eligible for inclusion based on our criteria. This group had no observable differences in orthopedic or medical complication rates compared to controls. And you can see everything listed there. No p-values were significant. And then in regards to the BAST group, so birth assigned sex women taking testosterone, there were 3,055 patients eligible for inclusion in this group. This group demonstrated a statistically lower risk of implant complications following ankle ORAF, but no differences in any of the other listed orthopedic complications relative to controls. The birth assigned sex women taking testosterone also had lower rates of minor medical complications. This would include things such as DVT, and no observed differences in major medical complications. This would include things like PE. And you can see there the p-values for both minor medical complications was highly significant, and then implant complications was lower as well. We wanted to contextualize the volume of this patient population. It's not a particularly robust group of people, but the trends are increasing, especially over the past several years. So the number of patients receiving these medications was calculated both by year and by region. Between 2010 and 2019, both groups grew significantly, both birth assigned sex women taking testosterone and men taking estrogen. The BAST group grew by a factor of 14.1, and the base group grew by a factor of 8.4. So as evident by last slide and some conclusions here, orthopedic surgeons will encounter an increasing number of transgender patients over the years to come, and this population, based on this research study, does not demonstrate a clinically significant increased risk of ankle fracture surgery compared to a control population. In fact, based on this data here, there's a slightly lower risk of implant complication in the BAST group. And while gender-affirming hormone therapy is traditionally regarded as a safe medical intervention, it's reassuring based on this study that we didn't demonstrate an increased risk of medical complications, which included thromboembolic phenomenon, which is known to be associated with some estrogen-based therapies. So based on this information, we feel that providers can counsel this population that hormone therapy does not complicate ankle fracture surgery and can proceed with indicated concern without any bias or concern for additional risks. Study limitations here include retrospective database design, analysis of only one fracture type, and a limited specificity in identifying transgender patients, but further directions would include addressing such concerns with things like prospective analysis and evaluation of different fracture types. That is it.
Yeah, take a seat up here. We have a panel for 15 minutes.
Good morning. I'm going to be talking about timing of olecranon fracture fixation and how it affects early complication and reoperation rates. Myself and the other members of the study don't have any disclosures pertaining to the topic. So olecranon fractures are fairly common. They represent up to 10% of all upper extremity fractures. When you think about the olecranon and its anatomic position posterior on the elbow, it's directly subcutaneous. So there's some unique anatomic considerations, especially when you think about the flexion extension arc and maximum flexion and the stress it puts on the posterior soft tissue envelope. It can be tenuous. When we think about fracture fixation of olecranons, you think about common complications, including symptomatic hardware, stiffness, ulnar neuritis, and a few others. So the purpose of our study was to assess whether or not timing of olecranon fracture fixation affects complication and reoperation rates. And we hypothesized that there would be no difference in complication or operation rates when you stratify by timing of fixation. So this is a retrospective study. 165 patients were ultimately identified using CPT code 24685, which represents proximal ulna fixation. And then ultimately 97 patients were included in our study over a 10-year period. So all patients who underwent olecranon fracture fixation, regardless of pattern or type, were included. All other fractures other than olecranon fractures that were included in that code were excluded. All pediatric patients were also excluded, and then patients must have a 10-week follow-up period in order to be included. So we divided our patients into early, standard, and delayed fixation groups. Early fixation was defined as any fixation before 3 days. Standard fixation was any fixation between 3 and 14 days, and then delayed fixation greater than 14 days. A recent study published in JHS defined delayed fixation in upper extremity trauma as 14 days, specifically for distal radius fractures. Otherwise, no studies had looked at surgical timing with relationship to fixation and outcomes. Our primary outcome for this study were the total complication and reoperation rates, and then our secondary outcome were patient-specific factors looking at complication, reoperation, and timing of fixation. As far as demographics, there were no significant differences in BMI, obesity, and smoking status amongst the 3 different groups. The early fixation cohort was significantly associated with both a younger age and having significantly more men when compared to both the standard and delayed fixation groups. And then polytrauma and open fracture were significantly more common in that early fixation cohort as well. There was no difference in sex, age, and incidence of polytrauma or open fracture when comparing between the standard and delayed fixation cohorts. So as far as complication and reoperations, our overall complication rate in our cohort, the whole cohort, was 37.1%. Previous literature had similar with regard to complication rate, roughly 30%. Our overall reoperation rate was 23.7%. When you look at across the groups, there were no significant differences in complication or reoperation rates. Our most common complication was painful hardware, followed by ulnar neuropathy, and then wound healing complications. And then our most common reason for reoperation was removal of hardware, followed by IND. And then looking at our secondary outcomes. So we wanted to know whether patient factors and how they affected or how they were associated with complications and reoperations. So we found that smoking was significantly associated with an increased complication rate with an odds ratio of 3.99, and that open fracture was significantly associated with an increased rate of reoperation with an odds ratio of 8. And then lastly, we wanted to assess whether or not some of these factors also affected or were associated with surgical timing. Our average time to surgery across our cohort was 9.3 days. Polytrauma itself and open fracture were significantly associated with earlier fixation. And that sort of goes in line with what we talked about before about how the patients in the early cohort had more polytrauma and open fractures. And then smoking was significantly associated with a later time to surgical fixation. So ultimately, we concluded that timing of olecranon fracture fixation is not associated or was not associated with a significant difference in early complication or reoperation rate. We concluded that surgical planning or medical optimization should take precedence over timing of fixation, both in that early trauma period and whether or not you're seeing these in clinic at a later date. You really need to think about those medical comorbidities and maybe also the patient factors and how they present or injury factors. I think limitations to our study, we think that this is a retrospective study, obviously. We may have been able to pull more data in the sense using our CPT codes, but I think sometimes that's challenging the way our system works. So I think we may be missing some amounts of patients that could have been included. But ultimately, over that 10-week period, those are the amount of patients we have from a follow-up perspective. Here at UVA, we also talk about how patients, if they're doing well, coming to clinic at the 6-week mark are often said follow PRN or as needed. And I think that limits our study a little bit because our surgical follow-up is a little bit shorter than it may be for other types of trauma. But otherwise, we came to that conclusion that fracture fixation is not associated with early complication or reoperations at that 10-week period. Thank you. So if you guys have the last slide, huh? Okay, good morning. So I'm going to be talking about development proof of concept of a novel 3D based preoperative planning software for pelvic fractures. I have no disclosures this time. So previously, the only images available for orthopedists for evaluation fractures were plain film X-rays. Now, with the expansion of CT scanners, three-dimensional imaging in the form of these CT scans are ubiquitous and almost universally used for operative decision-making. Now, over the last 10 years, computing power has increased and three-dimensional images can be more easily volume rendered, providing even more spatial information regarding fracture morphology. But it seems intuitive that we can process three-dimensional images faster. And there's research that supports that our surgical decision-making is improved when we look at 3D versus 2D imaging. But why does our preoperative planning at best still look like this? And our preoperative planning software still looks like this. So that's what we thought there might be an option to improve that. And so what we've done is we've developed software that allows us to essentially fully leverage the three-dimensional imaging that we're getting routinely to create more accurate and more tangible preoperative plans. And so here's how it works. Essentially, first a CT scan is obtained, and that CT scan is imported into the software to create a volume rendered model. Then within the software, a plate can be selected and contoured to the region of interest on the contralateral uninjured side. And so once you're satisfied with that plate position and contour, it can be exported and 3D printed. And then after that, a generic recon plate or whatever plate you decided to model can be molded to that templated plate, sterilized, and then implanted, providing a patient custom implant, as well as serving as a verification of anatomic reduction of your fracture. So we're actually able to use this workflow in this case. So there's a 71-year-old female who had a ground level fall during a Zumba class, and she sustained this posterior wall, posterior column acetabular fracture with a corresponding posterior hip dislocation. And so she was taking a surgery and her posterior wall fragment was reduced and the plate was contoured in the usual fashion and shown to fit well clinically. And so a second plate was then contoured during that surgery to match the implanted plate and was taken off the field. So then we used her CT scan and we used our software and the method we just discussed to create a template that we believe would be appropriate based on the fracture morphology, based on the contralateral side. And and this shows the plate that was contoured intraoperatively on the right and the plate that was designed and printed from the software on the left. And so I think while this is cool, I think we can also kind of walk through exactly what the interface of the software looks like at this time. So you boot it up and you can load in a DICOM file based on the CT scan. So you can download the CT scan. And here you can see the evaluation of that posterior wall, posterior column fracture and then the contralateral uninjured side. And so you can import a plate of various sizes, and then those plates can be bent manually. And we'll also show an auto contour feature here. And so you select areas of vertices, and then you're able to toggle up and down to bend the plate. And then you can also bend on the lateral side, creating more of a helical bend if needed. And then that plate can then be exported in that format. And so this is one of the newer features that we just pulled in, which is essentially you can draw on that surface, and then that creates a model of that specific surface, and then you can pull that model that you created off the off the pelvis, and then print that, and that can also serve as a template. We're working on making sure that actually just prints a model of the plate, so you can have an idea of exactly how long of a plate and exactly what that looks like. So, so future directions of this. Now, as you might astutely imagine, there's no data associated with this project this time, and so what we'd like to do is, have a survey first to evaluate the utility and ease of use of these custom contour plates and stratify it based on
years in practice and level of training, and see if that, is more, shows more utility with a certain population or another. And then ideally maybe a randomized trial comparing surgical time and fluoroscopic time in acetabular cases where the software is utilized and where it isn't, and trying to see if that is there's any difference there. And then we're also going to be printing in different material that allows you to sterilize these plate templates and bring them into the operating room with you, so that you can contour them on the back table as opposed to having to think about this ahead of time potentially. And then overlying the morphology of the fracture of the injured side over the uninjured side, so you can really optimize your plate placement for the fragments that you're dealing with. And so, just want to acknowledge REOs for doing all the heavy lifting and debugging of the software, which has been fairly challenging. Dr. D, Dr. Weiss, and Dr. Yarborough for letting me pick their brains and bug them at all hours of the day about this. And Dr. Chabra and the whole department for giving us resources like 3D printer and funding for it that allows projects like this to happen. So thanks.
Good morning. Nothing quite like a basic science talk on a Wednesday morning. So today I'll be talking about immunomodulation of macrophages in intervertebral disc degeneration. I have no financial relationship or conflict of interest to declare in this presentation. This talk was supported by the RIEF Resident Research Grant. So low back pain is a pretty common problem we see. Up to 50% of the population can manifest up by age 70 and has pretty significant socioeconomic burden. Costs about 2% of the GDP in most Western countries due to productivity loss and disability. Multiple causes of low back pain, in particular disc herniation and degeneration are common causes. And it's usually a combination of aging, genetic predisposition, the mechanical forces that these discs experience, as well as the biochemical environment that they undergo. We also know that inflammation and disc degeneration and herniation are significantly inherently linked. Inflammatory cells and cytokines mediate the acute process of disc herniation. In a mouse model, during a disc puncture model to simulate a disc herniation, what we see is significant infiltration of macrophages into the local injury site. Additionally, we know that macrophage exists on a spectrum. They display different phenotypes depending on the tissue and disease process, depending on the local soluble factors. So an undifferentiated M0 macrophage, depending on its induction factors, can become an M1 pro-inflammatory macrophage. Alternatively, they can also become an M2 anti-inflammatory macrophage. The reality is they exist in a heterogeneous population. In a disc puncture model, significant infiltration of leukocytes are there, and when we do immunostaining of these discs, we see a combination of M0, M1, and M2 macrophages into the injury site. So our overall question that we want to answer is, what are these macrophages that exist in disc degeneration, disc herniation? What are the phenotype of these macrophages? And alternatively, what do these macrophages do to the discs? And what is the crosstalk relationship between these two entities? And the long-term goal is, can we leverage this relationship for therapeutic benefit? So here's a working hypothesis. So a disc degeneration will cause undifferentiated macrophages to differentiate into M1 pro-inflammatory macrophage, which in turn exacerbates disc degeneration, forming this vicious cycle of worsening disc degeneration. However, if we were to artificially induce these undifferentiated macrophages to form M2 anti-inflammatory macrophage, potentially either slow or reverse the amount of damage that these discs experience. And we'll study the process under a novel disc-on-chip model. So the disc-on-chip is a device that was developed by one of our research partners. It's a novel microfluidic device that continuously delivers nutrients to these discs using automated syringe pumps. They circulate these growth medium into these disc chambers, which, and what we've demonstrated is that these increase the cellular viability, as well as improve the structural integrity of these discs, and also preserve some of the native anabolic and catabolic relationship compared to a static well culture. So the first part of our project, we wanted to see if disc degeneration can induce an M1 pro-inflammatory phenotype in these macrophages. We first induced treated disc with interleukin-1, and as you can see on the left graph, increasing concentration of interleukin-1 increased breakdown of the extracellular matrix of these discs, as well as increased nitrite, which is a marker for inflammation. Now, when we co-culture these degenerated discs with macrophages, we see increased expression of interleukin-1 on immunohistology, showing increased M1 phenotype. Next, we wanted to see if the M1 phenotype can actually exacerbate disc degeneration. So we pre-treated these discs with lipopolysaccharide to polarize them to M1 and co-cultured with the discs. What we see is there's from PCR results, we see a decrease in expression in anabolic genes, including collagen 2 and aggrecan, as well as an increase in catabolic genes, a release of glycosaminoglycans into the media. Finally, what if we can induce these macrophages into M2 anti-inflammatory phenotype, how that can preserve the disc structure. So this is a Alcium blue staining of annulus fibrosis of these discs. The control cells, you can see the maintained structure of the annulus fibrosis, and this is a degenerated discs treated with interleukin-1. Now, when we culture with M2 phenotype, you can see improved cellular structure. And this is also shown in our gene expression results. We can see improvement in anabolic gene expression, as well as decrease in catabolic gene expression as a result. So conclusions that we can draw from the study is that degenerated discs can polarize these undifferentiated macrophages into an M1 pro-inflammatory phenotype, whereas M0 and M1 macrophages can accelerate disc degeneration as a result. And M2 macrophages can slow disc degeneration. Future direction we want to proceed with the study is we want to establish a more optimized culture protocol and examine the soluble factors that these M2 anti-inflammatory macrophages secrete contributes to its protective effects. And finally, we would like to translate these findings into in vivo situation. Well, I'd like to acknowledge the research team for their help and guidance on this project. Dr. Lee, Dr. Jin, Dr. Xiao, Grace, Zhang Yi, and Qi for their help with this project.
I have some questions, okay? Okay, I'm gonna class and you the program study based on and then you a lot of people take estrogen going through gender
Or gender change. So don't you think you potentially overestimated the number of subjects?
So to specify particularly, we only stratified, so birth assigned sex men, we only looked at them taking estrogen. So no men, birth assigned sex men taking testosterone were included. And then there are very, very few medically approved and supported indications for birth assigned sex men to take estrogen. There aren't actually any that have strong evidence. And then birth assigned sex women taking testosterone, the only group that has strong research-based evidence for them to take testosterone is postmenopausal patients with like hyposexual function disorder. And we intentionally excluded patients over the age of 60 to try to eliminate any bias with hormone therapies in like the postmenopausal group. So we tried to control for that as much as possible.
5. What's the timeline of how quickly can you use the software and print a plate so that we have a template to use and drop? Overnight, few hours?
So you can the software demo is essentially real time there, and so that you can model the plate in a couple of minutes to 20-30 minutes. The print time for one plate is somewhere in 45 minutes to an hour and a half, depending on how much infill, how long the plate is. It's pretty reliable. This might be able to do it from getting a consult in the morning at 9 a.m. to being the last case of the day.
And do you need any special equipment to bend these plates intra-op based on the template, or do we already have everything in-house?
I don't know the answer to. I think that if you have that template, you should be able to just bend them in the way that you normally be able to bend a plate, but I'm not actually sure about that.
Michael was better be able to about.
That was loud enough. Okay. So, I don't know if it's on or not.
So let me piggyback onto that question. How much, so in spine, we have UniD, which is this idea that you have a pre-bent rod that's sent to you to match the alignment that you want to make in a deformity case of the spine. Similar idea here, and it does make a difference, but what is the time saved in the operating room for this versus, say, cost or something like that? Is somebody like Dr. Yarbrough going to be able to bend it in 2 minutes without a template, or is there no, is it not that straightforward?
Yeah, that's a good question. I think it comes down to obviously surgeon experience, but as far as time and resource utilization for this, I know we were kind of talking beforehand, but for all of the 3D printing that we've done as a department at this point over the last year, I think the total cost of filament has been less than $60. So for each one of these plates, the cost is somewhere on the order of cents to $1 at most. And that would even include for sterilizable, autoclavable versions of it. So the cost would be pretty minimal. Now, as far as the amount of time saved, I don't know the answer to that. I think what it would come down to is, surgeon experience, the kind of the serendipity of the fracture lines and the exposure. But maybe 10 or 15 minutes saved.
Yeah, the model is a little different because UniD, the rod comes already pre-bent, and this one you're matching it to a template, I guess.
Right, exactly.
The cost is less there. Quick question for Josh too. How come you guys? There's two statements you said during your talk that caught my attention. One was off the slide. You said you used a 10-week follow-up, which we routinely say fractures you have 12. And the second one was you say at 6 weeks, oftentimes you say follow-up is needed. So those two statements make us wonder, when you look at your data, is it capturing the complications when you have a 6-week clinical and a potentially 10-week radiographic follow-up?
So I think from a 10-week standpoint, anecdotally, we had talked about it and we had felt that at the 10-week mark, most fractures had healed enough. So you used this.
What do you have a sense of what most is though?
So I think almost 6 weeks from a follow-up perspective, patients are doing well clinically. I don't think necessarily radiographically we're healed at 6 weeks, but then 10 weeks radiographically would be our mark to say that we think that they're radiographically. I don't have an exact number.
That's fair. Do you think it'd be able to get out to 3 months or 6 months, which is obviously for presentations to national meetings?
We have data looking at 3 and 6 months. The amount of patients that we lose at the 6-month mark is significant relative to the 3-month mark, but there's not a significant difference in the amount of patients we lose between the 3 months and 10-week mark. I think it's actually only 10 patients, like 97 versus 107. So we use that 10-week mark period.
Josh, did you differentiate between the type of hardware used?
We did not. I think 97% of the patients in our study underwent plate fixation.
Okay.
And most often, I think here we use the VA locking electron plates.
So hardware removable is pretty common for electron fractures. And one of the things I've always worried about is fixing them in a closed situation, fixing them acutely when they have a hematoma and quite a bit of swelling, that you're going to get a wound complication. But you're saying that in the study, it didn't matter. Were the vast majority fixed within 3 days, open fractures?
I don't know the exact number of open fractures in this first 3 days.
So I think that should be something to be looked at, stratifying between closed injuries treated within 3 days, then the mid-time point, and then further out, because I'm curious to know if you have a lot of hematoma swelling initially in a situation where there's already a high wound complication rate and hardware issue in a closed situation, whether fixing them early would potentially lead to more wound complications. So we should look into that question.
JT, your study is great. It's using this organ culture system. It's easier to test, single agents. But that system doesn't really simulate the human body. in vivo environment. Do you have any idea how can you actually design in the future to more simulate the human spine, environment to, that way maybe single out one factor?
Dr. Trey, thank you for your comment. And it's very true in a native discs, they don't experience circulating growth medium. And additionally, in our system, we don't have the mechanical forces that we see in a native disc. There are certain devices that are out there that can apply pressure to these, axial pressure to these discs to try to simulate that native environment much better, and using the more specific growth medium specific to these cells, such as low oxygen tension, to be able to better mimic the native environment.
Jesse, as someone who's experienced a disc herniation, I assume the inflammatory response can be positive with regard to disc resorption and alleviation of symptoms. So inflammation is a critical step in healing. So you're blocking the inflammation process. Is there going to be a consequence of doing that? Because if you don't have inflammation with a fracture, you're not going to get healing, right? That's how you recruit appropriate cells to the environment for healing. Same thing for disc herniation. Maybe that results in disc resorption and alleviation of symptoms. I understand that prolonged inflammation can cause problems with disc degeneration, but blocking the inflammatory process, what do you think the consequences will be?
I agree with you. I think what I can envision in the future is to allow early inflammation to resorb that acute disc herniation, and then address the late phase to minimize inflammation, to try to decrease the sequela of disc degeneration in the late phase.
So the next step is how you therapeutically do it. If the disc is avascular, immune protected space, and we know that putting a needle on the disc accelerates degeneration, how do you deliver therapy locally?
I think that's still a work in progress, but potentially can consider polarizing, so obtaining macrophages from the host and polarizing them to anti-inflammatory macrophages, and finding a way to deliver them locally, whether through like epidural injections, things like that.
But have you done the market research? How much is the market going to be? That means, this is your creative idea. You needed to look at that, and also the software needed to be, intellectually protected. So many companies are looking for such, creative ideas. They can, so many new technology also on the market already. So it's going to be very competitive. So have you any idea, your plan? What's the next step?
Yeah, so essentially, the UVA is a really good group for licensing ventures that allow for licensing of all any technology produced at UVA. So that would probably be one of our next steps moving forward with this.
Did you talk to them yet?
Not yet. That is
sooner than later.
Yeah, that would be the next step. But as far as you kind of asked what the market potential looks like for this, I think what's been interesting about 3D printing is that it's widely it's been a buzzword for almost 2 decades now. But the thing that people have focused on is fully printing an entire pelvis or like an entire fracture, and basically printing that, and then, we'll fix this in a sawbones way, and that'll train us for the actual surgery. And it's clunky, and it's expensive, and it's time consuming, and that's the thing that takes 30 plus 40 hours to print, just to do the surgery that you're already gonna have to do. That has shown benefits, but it's just really mostly for educational use. And then on the flip side, software that has looked at 3D modeling and then fragmenting out each of your fragments, they focused a lot more on reducing the fracture in 3D space, and then showing that it can be done. But again, not if you look at some of the demos of those that are widely available, it's not it doesn't really correlate clinically, right? Because they just take this dusted proximal tibia fracture, and then just like a jigsaw puzzle, just put the pieces back together and show, look, we can reduce it, and this will help you with your surgery. And that's just, I don't think that's necessarily how how it works in real life. So this actually provides a good option to leverage all of the advances with technology, with the 3D imaging and 3D planning and 3D printing, and do it in a way that's fast and effective and potentially useful for addressing clinical outcomes. So that's something we're pretty excited about.
What is the, I mean, 3D printers are not that expensive anymore. It's the material, right?
Yeah.
What is the ability to actually bring in and create our plates in-house?
So that's where it gets so that's where the regulation gets a little bit more challenging. So long as you are not producing the thing that is implanted, my understanding is that it doesn't necessarily require that full authorization and the full like implantable device stuff from the FDA, because all you're doing is you're creating a template that will never probably see any type of direct patient contact. As far as printing our own plates, and that is potentially an option you can go with this, right? As you saw the draw on surface contour, you could viably do something where you draw a more complex surface and a complex pattern, and then print that as a custom, almost like a quadrilateral surface plate or something like that. That would be possible with, I would argue, with our printer, but because you could print in metal, but then that would be, the turnaround time would be a lot longer. That would be more in the weeks area, because you need to send that away for the processing and bring back, sterilize it, and the regulatory hurdles on that would also be far more challenging in time and cost.
Quick comment on that is, you as a surgeon can do anything you want with any implant you want. You use popsicle sticks to fix fractures, but it's all on you. There's no such system that has FDA approval for use as a virtual inventory, which if maxillofacial folks use those a lot, and some of those systems are approved. There's a lot less stress in the face, it turns out, than in the pelvic ring. So, I think something like that may be coming on the pipeline, but it's not there yet. And so I think he's made great progress in really a short amount of time. And to Dr. Shen's point, the posterior acetabulum is not really where the clinical need is, but it's a great place to kind of refine the process. So if you could figure out how to do it smoothly and effectively for the posterior acetabulum and then apply it to the anterior approach to the acetabulum, for example, where contouring plates and figuring out plate size and fit for the pelvic brim is much more challenging, then I think it would be time well spent.
Jesse, that was a lot of data that you presented. Could you basically share your role in the project, the specifics?
Yeah, so a lot of the project design was supported by Dr. Lee and his research group. I helped form some of the assays, including some of the nitrite assays and PCRs, and help put together some of the statistics as well.
And you obtained the OREF resident research grant.
Katie, just a comment more than anything else. I always try to resolve this issue where we know that estrogen increases VTE issues just in general through studies in multiple specialties over the course of multiple years and decades. And then we have a study that says there's no increase, to the best of your knowledge, retrospective pro-Viver, that there's no increase in estrogen in that patient population. And I think they're both accurate, but I always try to resolve when there's large studies that show something that is very different. Does it speak to the patient population when something that's been so clearly defined? And it's more of a comment and what your thoughts are on that, which makes it a question, I guess.
I had the same question for myself when I got the data. I really was just anticipating seeing an elevation, especially because the levels of estrogen the erythrocyte sex men are on is very high. You're trying to reach like a super therapeutic level. So I really did anticipate it, whether or not it's some, genetic, erythrocyte sex male, lack of, genetically levels of estrogen at baseline that is running it. I don't know the physiologic reason. I think part of my purpose in doing this study was to get the ball rolling on research like this. And I think just a lot more needs to be done, and more might be done, and that finding might be disproven.
Yeah, and so the second thing then is we don't know, maybe at 15, 20, and 30 years, testosterone on female birth assigned and estrogen on male birth assigned at 15 years or 20 years, what those effects are like.
Correct. But hypothetically, that's outside of the post-operative complication.
Correct. Yes. Yes.
Any more questions? Move on. Thank you, guys.
Good, great.
As Monica's getting ready, or just a comment. So as of July 5th, all our clinics will have Promise activated, right? Hand has done this now for several months, and now, and then sports is going to follow later on this summer. So Promise questionnaires are filled out by our patients. They're immediately uploaded to Epic. It'll be an opportunity to do a lot of great prospective, retrospective study on our own patients. And we're already having 60+% of our patients at the hand center entering Promise their surveys every time they come to clinic. So it's a massive amount of data. So I really think that if this is a great opportunity moving forward for projects for next year's presentations and so forth. But all clinics should be fully functional with service-specific surveys by the end of the summer.
Are we waiting until 7:45 or are we just rolling? All right. So I'll be talking today about simplifying post-operative rehabilitation protocols after ankle fracture operative fixation to look at improving post-operative range of motion and patient-reported outcomes. So why do we care about this? So ankle fractures are some of the most common injuries encountered by orthopedic surgeons. Oftentimes, post-op rehab protocols are employed in an attempt to avoid post-traumatic range of motion limitations. And anterior ankle impingement and pain with dorsiflexion is one of those most frequent complaints that are cited. The difficulty with some of these protocols is that they can be lengthy, they can be difficult to explain to patients in the clinic for these home exercise therapy, ultimately potentially leading to decreased patient compliance and possibly poorer patient outcomes. They've looked at this in other departments, in the emergency department, as far as how complex are these things that we're telling patients to do at home, and then how much can they actually comply with this reasonably. So our goal was to investigate the comparison in pain, promise, and measurable ankle dorsiflexion after ankle fracture fixation with 2 postoperative therapy protocols. So our hypothesis was to look into the non-inferiority of a simplified ankle block stretch to target maintaining ankle dorsiflexion as compared to the standard AAOS home exercise protocol after ankle fixation or formal physical therapy for the above metrics. So the study design is a randomized controlled trial taking postoperative ankle fracture protocol, comparing a simple ankle block stretch to target that dorsiflexion. And then our control in this study was the home therapy program or formal physical therapy. Our inclusion criteria is patients 18 to 65 having sustained an operative bimal or trimal ankle fracture, pilon fracture, or fracture dislocation, and then after their final operative fixation. So mode of fixation was not impacted by the study. It was all surgeon preference. We excluded patients that had contralateral lower extremity injuries that might impact their rehab afterwards on the ankle that we're looking at. Any prior ipsilateral ankle injury, any baseline neurologic deficits that would limit them in participating, and any severe injury requiring vascular or soft tissue reconstruction if the patients were ambulatory or their BMI was over 50. This is the example of our patients that were randomized to our ankle block stretch group. So they were given a single physical therapy exercise to perform starting at their 2-week follow-up visit. They were allowed to bear weight for this exercise only twice a day and then return to either their non-weight bearing or touchdown weight bearing and per their post-op protocol. We selected this standardized block 1.5 inches tall, 3.5 inches deep to fit to the average foot size in order to get about 10 to 15 degrees of stretch. And these were provided to the patients. And this was the actual paper given to patients in the office as well. This is an example of our control group. So this is some of the exercises from the home exercise program that's typically given to these patients that have several different exercises. The towel stretch is probably the most similar to the ankle block stretch. So it is in there, but it's within all of these other exercises. So we measured our patients at 6 weeks, 12 weeks, and 6 months follow-up. Our primary outcomes were measured ankle dorsiflexion with an inclinometer. And then we also compared the ankle dorsiflexion compared to the patient's contralateral uninjured ankle. So this was our own internal control. Obviously, some people at baseline are more stiff than others. So we use their uninjured ankle as a control. Secondary outcomes were patients' promise scores and pain scores. And data was collected by our in-house research coordinator and measured by some trained medical assistants and physicians. And this was all through the REDCap data management system. And that was where they were randomized as well. As far as the demographics of our two groups, so we're still, patient enrollment's almost complete. We have most of our 6-week data in here, but these are our two groups. There's no significant difference in gender, age, BMI, or injury classification, whether it was a rotational injury or more of a pilon injury. And then I think this data is still impactful that we have most of our 6-week data. Presumably, if you can maintain motion from 2 weeks when they come out of the splint up to their 6 week, they can maintain that moving forward. So I still think we have more collection to do, but this can at least show us where we're at right now. So these are our results. The first chart at the top is comparing our absolute ankle dorsiflexion between the two groups at 6 weeks and then at 12 weeks. There was no statistical difference between those two groups. Jumping down, looking at the percentage of each individual patient's baseline dorsiflexion compared to their operative side. There was no statistical significant difference between the two, but there is a slight trend at 6 weeks, our ankle block group having slightly better range of motion than our home exercise control group. Pain was also not significantly different between these two groups, and we're still working on incorporating all of the promise scores into our data between the two groups. So like I mentioned, overall, no statistical or statistically significant difference in pain or our range of motion or percentage of their baseline range of motion. But there is a trend at the 6 week mark for the ankle block stretch group to have a little bit more of their baseline dorsiflexion back. So ultimately, there was a non-inferiority of the simplified protocol, which is promising in the sense that they had similar outcomes and PROs, might be able to boost patient compliance with simplifying our therapy protocols, but still getting just as good outcomes is our goal. We do have some limitations to the study. We're still collecting data at our 12 weeks and 6 month mark, so that may change when we have everybody included. So at this point, we still have a pretty small sample size, but that should be improving. We're still analyzing our secondary outcomes and all of our promise scores. And then another limitation is the margin of error for the inclinometer measurements in clinic. We don't have a clearly defined range that margin of error is. So in conclusion, anterior ankle impingement due to arthrofibrosis is a very common problem after ankle trauma. Focused ankle dorsiflexion program with early weight bearing for stretching is safe. We didn't have any patients that had hardware complication with this change. A simple exercise program is easier to explain and to understand for patients. So that is one benefit from this. And these short-term results of a simplified home therapy program focusing on reestablishing our most commonly cited postoperative range of motion limitation is non-inferior to a similar AAOS approved home exercise program. So I think that moving forward, this can be employed across different specialties, trying to focus on the one thing that patients struggle with the most. And if we can target those with more simplified therapy protocols, patients can actually do them and be more compliant. So I think in addition to this, we can start collecting just compliance data, self-reported compliance data with this to see if it does help being more simple.
All right, so I'm going to talk this morning about a project I did with Dr. Dacus looking at day of surgery blood glucose levels and complications following carpal tunnel release. So we all know that diabetes is a risk factor for developing carpal tunnel syndrome, and there's been lots of literature showing that both A1C levels and diabetes are both risk factors for post-op complications in hand surgery, particularly wound problems and infections. However, there have been few studies that have looked at specifically day of surgery blood glucose levels and complications in hand surgery. So this is kind of a specific thing to look at. So why do we care? I think the obvious and kind of generic response is that, knowing this can help us counsel patients pre-op so that they know their own risk factors following surgery. But I think more importantly, hyperglycemia is a cited reason for same-day surgery cancellations. And when we have these cancellations, hospitals and us lose money, we lose our OR time, and then the patient gets frustrated because they show up expecting to have a surgery and then they get told that they can't have it. So we hypothesized that elevated blood glucose was not correlated or would not be correlated with increased complications following carpal tunnel release. And we looked at this with a retrospective chart review of UVA patients undergoing carpal tunnel release between January 2020 and October 2022. They had to have a day of surgery blood glucose level, and we used a cutoff of 200 to differentiate between our control group and our hyperglycemia group. Our primary outcome was complication rate, both overall and then divided into major complications and minor complications. Major complications were defined as surgical site infections requiring antibiotics or operative debridement, wound complications requiring a return to the OR, and then revision surgeries. Minor complications were defined as delayed wound healing, scar hypersensitivity, and then a recurrence of symptoms that didn't warrant revision surgery. So overall, we had 357 patients included in our chart review. This is a table that outlines our demographics. So we didn't see any statistically significant difference in patient age, sex, smoking status, severity of carpal tunnel syndrome, percent of procedures that were revisions rather than the primary surgeries, percent of diabetes diagnosis, and then prevalence of neuropathy as diagnosed on EMG. We did see a statistically significant difference between the groups in average A1C, with the hyperglycemia group being higher on average. Then when we looked at complication rates, so looking at overall complications in our control group, about 23% of the patients experienced at least one complication, whereas about 31% of the hyperglycemia group had a complication. Looking at minor complications, it was about 21% versus 24%, and then major complications was about 4% versus about 7%. So you can see small differences between the groups here, but when we did the stats, none of it ended up being statistically significant. And so when we talk about what this kind of means, I think it suggests that a one-time hyperglycemia event doesn't increase your complication rate following a carpal tunnel release. And we saw similar complication rates as reported in other literature looking at this. So this data suggests that maybe we shouldn't be canceling these cases just because they have a high blood glucose the morning of surgery. I think it's a huge benefit to the patient to not have to come all the way here and then have their surgery canceled, especially if it's proven that it's safe to proceed with surgery. And then it has a financial incentive for us in the hospital to keep doing these surgeries rather than canceling them day of. I think the big limitations for this study is that it's retrospective, and we ended up having to lower our blood glucose cutoff in order to properly power it. We wanted it to have a higher cutoff, about 250, but we just didn't have enough complications captured or enough patients included to really see a difference or be able to detect a difference between groups. But I think this data opens up the door for kind of future studies, specifically looking at expanding the data to include other simple hand procedures like trigger finger releases. And I think it would also be interesting to look at the UVA surgery cancellation data. I personally reviewed about a third of the charts and came across probably 2 or 3 patients that were canceled because of hyperglycemia, and we couldn't include that in the study. And so I think it'd be interesting to actually get concrete numbers to see how many cases are canceled for this reason, to better understand the financial and patient burden on the system for these cancellations. That's all I have. Thanks.
So my talk is an analysis of the incidence, risk factors, and timing of development of cyclops lesions after anterior cruciate ligament reconstruction. So localized anterior arthrofibrosis, also known as a cyclops lesion, is a well-described complication after ACL reconstruction. Incidence has been described between 2 and 11%. These lesions may be discovered asymptomatically. However, they also may present with pain and loss of terminal extension. Usually about 90% of these cases have been described as being diagnosed within 6 months after surgery. And in symptomatic patients, treatment is typically arthroscopic excision, which usually improves range of motion with low overall recurrence rates. These lesions are theorized to be due to repetitive microtrauma in the setting of impingement of the ACL graft on the notch. Thus, many of the risk factors kind of go off this idea. So whether the tunnel in the tibia is placed too anteriorly, whether there are some factors that increase your graft to notch diameter, so smaller patients or basically larger graft leading to increased rates of impingement. However, data in the literature is conflicting. And so our primary goal was to try to one, identify incidence and timing, but then also associated risk factors as a way of trying to assist with primary prevention of developing these lesions. Secondarily, we wanted to assess differences in functional outcomes that we use for return to sport purposes in patients with cyclops lesions versus those without. So we did a retrospective review of 313 patients who underwent ACL reconstruction and subsequently completed our lower extremity assessment protocol at 6 months post-op. This is a standardized functional outcome series of measures, hop testing, strength testing, et cetera, that our patients undergo prior to return to sport. Surgeries were done between 2013 and 2018, and all were completed at this institution by fellows trained sports medicine surgeons. So preoperatively, we looked at demographics, age, gender, BMI, and then we also looked at timing between the injury and their surgery, as there have been reports suggesting that both early and delayed surgery could potentially be risk factors for development of a cyclops lesions. Operatively, we looked at the type of graft used, the diameter of graft, the tunnels sizes that were used, any concomitant procedures that were performed. And then post-operatively, we looked at range of motion at 6-week, 3-month, and 6-month time intervals, as well as the LEAP data. So our primary endpoint was identification of a cyclops lesion, whether on MRI versus arthroscopy, and then determining whether these were symptomatic versus asymptomatic, and ultimately whether the patient required arthroscopic excision of the cyclops lesion. Secondarily, we looked at the functional performance testing based on the presence of cyclops lesion. So overall, we identified 23 patients in our 313 who had a cyclops lesion, or 7.4%, with a mean time to diagnosis of 18 months. 17 of these patients were symptomatic, and 10, or overall about 3%, required arthroscopic excision of the cyclops lesion. When we looked at pre and intra-op risk factors, the only finding in our group that was significantly associated with development of a cyclops lesion was concomitant meniscus repair. None of the features with regards to our graft, time to surgery, gender, BMI, et cetera, seem to be associated, at least in our study. This is a comparison of our LEAP data with patients at 6 months who developed a cyclops versus who did not, as well as their IKDC scores, and there was no significant difference between the two groups at 6 months. And when we looked at range of motion, so at 6-week intervals, patients who ultimately went on to develop a cyclops lesion had actually a lower range of knee flexion. This is likely due to the fact that our meniscal repair patients are limited 0 to 90 post-operatively, and as they had a higher rate of cyclops lesions, that's probably what this is reflecting. And then looking at 3-month and 6-month time intervals, there was a marginal, though significant, decrease in extension found in the patients who had a cyclops lesion. So overall, 23 total cyclops lesions identified, 17 were symptomatic, and 10, so about 3%, required reoperation. At least in this study, we did not find any association between the timing to surgery, gender, BMI, graft size, et cetera. As mentioned, meniscal repair intraoperatively was the only finding that was associated with development of a cyclops lesion. As noted, so patients who undergo meniscus repair at this institution are limited to partial weight bearing, as well as range of motion 0 to 90, compared to somebody who gets ACL reconstruction alone would not have any weight bearing restrictions or range of motion restrictions. So it's difficult to discern whether it's something inherent to the meniscus repair versus partial weight bearing, limiting the ability to achieve full extension postoperatively. The mean time to diagnosis in our study was 18 months. This is somewhat limited by the fact that we did include incidental findings as well. However, at least at the 6-month time point, we didn't see significant difference in functional outcomes, and tough to say whether our extension deficit at the 6-month time point is clinically significant, whereas much prior literature suggests that these lesions are symptomatic and diagnosed within 6 months. So this was a retrospective review, and then we did not obtain postoperative imaging on all of these patients. So we did identify some asymptomatic patients, and that also does skew our time to diagnosis as mentioned. But so in conclusion, concomitant meniscal repair could potentially be a risk factor for development of a cyclops lesion after ACL reconstruction, though it is unclear whether this is something inherent to meniscal repair or our postoperative range of motion and weight-bearing protocols. And then symptomatic cyclops lesions may potentially present later than originally believed, at least when symptoms begin to develop, and should be considered in a late extension loss in a patient after ACL reconstruction. Thank you.
This is a topic that's near and dear to my heart. And this is evaluation of weekend operating room delays at a level 1 trauma center, aka our level 1 trauma center. So this is a typical Saturday. This was 2 weekends ago. There's at least 5 attendings on call every weekend. There are 5 residents on call. So it's about 20% of our residency that sits there every Saturday morning, brings the patient down to pre-op, helps set up the room, and still waits until about 8 a.m. So why is this important? 1, talking about healthcare expenses. They're increasing, but often fall short of patients' expectations of quality of care. 2, operating rooms are a vital yet expensive hospital resource, and as a result, represent a key target for reducing healthcare costs. And 3, on-time case starts first start of the day are usually used as a metric for determining OR efficiency. So the goal of this retrospective study was to quantify the most common causes of delay and on weekends within the Department of Orthopedic Surgery at our institution. So on-time first start in this particular study was defined as documented in-room time at 7:30. So this isn't even making incision. This is just we got into the room at 7:30 on a Saturday or on a Sunday. So the inclusion criteria was orthopedic surgery, trauma-related weekend cases staffed by the on-call general orthopedic attending. And we looked at the cases from January to December in 2022. So what did we find? So we found that in-room on average was 8:07 a.m. and the case start, so when you were making incision, each Saturday and Sunday was 8:43. This is for the entire 2022 calendar year. So you say, okay, well, when are these cases starting? So on average, Saturday is in blue, Sunday is in orange, and on average, these cases are starting between 8 and 10 a.m. There's a spike between 8 and 10 a.m., not much going on in the middle of the night, and definitely not much going on at 7:30 a.m. So reasons for delay. This is probably my favorite. So each case has a specific reason for delay associated with it. So you can do an individual chart review. So I decided to take our chairman. So our chairman's cases, he was just told it was the weekend. So he was told it was the weekend in April. He was told it was the weekend again in July. And then somewhere in September, the 4 medical students actually brought the patients to pre-op. So looking at reasons for delay, the 60% of the reasons for delay were other not reported. So that's when somebody just said, not even worth my time to say why it's delayed. 2 is OR delays. That could be equipment wasn't ready, the room wasn't set up, staffing wasn't there on time. And 3 was insufficient anesthesia coverage, because a lot of the times they're starting 3 or 4 rooms. They can run up to 5 rooms on a Saturday, but 3 or 4 rooms at one time. Realistically, they're not all starting at 7:30. So in conclusion, the study found that out of the 88 first start cases over 106 weekend days in 2022, not a single one started on time. So that is 0. That is 83% of the time orthopedic surgery has a first start case at UVA. Hopefully we're given a room for 4:30 a.m. And so I think you have to look at short and long-term goals. So I thought this was an appropriate form of discussion for this particular issue because it affects every single one of us. From a resident perspective, from an attending perspective, this is your own wasted weekend time that you could either be operating, you could be hanging out with your family, you could be taking care of patients. So there are cited factors which can be mitigated with further investigation. But I think in the short term, we have to, 1, start actually determining why these cases are not starting on time. So other is not an acceptable reason to actually come to some sort of meaningful conclusion and enact meaningful change. 2, by defining the process, the precise causes of delay, we can either say, hey, the OR start at 8 a.m. on the weekends and just call it what it is instead of at 7:30, and we all sleep in a little bit later, or we can use our ORs more efficiently and start them at 7:30.
So the title of my talk is a department review of the orthopedic weight-bearing terminology used here at the University of Virginia. So it's known that providers within our department use different terminology for providing post-operative weight-bearing recommendations to their patients. And anecdotally, we found that this was causing confusion within our department, but also with the therapists and with the patients, with some patients not following the correct weight-bearing recommendations that were prescribed to them. So this was leading to a miscommunication within our team, but also between our team and the therapy teams. So we wanted to look at that and investigate. So the purpose of the study was to investigate the terminology that was being used, and then determine how it was being interpreted by our team as well as the therapy teams and other providers in the hospital. For the study, we sent out a 7-question survey that was sent to all the orthopedic surgery attendings and residents, as well as the physical and occupational therapy teams. And that was done over the Qualtrics research suite. Following the results of that study, we met with the trauma team and some of the other specialty services here with the orthopedics team to come up with updated recommendations, which were then redistributed to the orthopedics team as well as to the physical and occupational therapy teams. And then a second survey was sent out to estimate how well we did in educating and consolidating the recommendations for postoperative management. So these are the questions from the initial survey. This first question deals with the position of the foot when patients are being prescribed a protected weight-bearing status. And this shows that there was some disagreement within, this is physicians only, so this is just the attendings and residents, disagreement about the placement of the foot on the ground. So whether or not this is foot flat on the ground, not transmitting weight, or if this is ball of the foot, with the foot in equinus, the knee flexed and the hip flexed as well. Second question, this is just how much weight is supposed to be transmitted through the limb while these patients are using their protected weight-bearing status. And this again shows disagreement within our department, the residents and attendings, on how much of their body weight should be transmitted through the axis of that extremity. And then this third question is what terminology they use when they're prescribing these protected weight-bearing status. So again, a wide variety. So I think these first 3 questions show that within the department, the terms that were being used by the attendings and the residents and their notes and how we communicate with the therapy teams, we were not using a uniform lexicon. We were using different terms to prescribe these restrictions. And then we were also disagreeing about how much weight should be transmitted and what the position of the foot should be. So this was leading to a miscommunication with the therapy teams and how they instruct our patients, and then how those patients rehab from their surgeries. There specifically seemed to be some problems with toe touch versus touchdown, but we wanted to go through and look at each of the terms. So non-weight bearing, a term that you think would be almost unanimous, we found was close, but only 92% accurately defined what we wanted for non-weight bearing. When we looked at toe touch weight bearing, there was a wide variety. So this was one of the most confusing terms for the therapists, and what the position of the foot should be and how much weight should be transmitted. So there was about 49 respondents out of 89, so about 50%, wanted the forefoot on the ball of the foot. So actually toe touch, touching their toes down, and then putting weight through that position. Touchdown weight bearing, when we use that term, about 58% of the therapists and residents and attendings understood that the foot should be placed flat. So there seemed to be a better understanding of what we actually wanted when we used touchdown weight bearing as opposed to toe touch. And then the last question was just for feedback from physicians and therapists, and that was actually pretty helpful. The therapists had a lot of recommendations and kind of helped elucidate what was so confusing for them when being prescribed these weight bearing recommendations. I think it was kind of helpful to see that they come with a background from where they were trained, wherever they went to their therapy schools, and they were taught specific terms. They were taught what those mean and how they should educate their patients. And that doesn't always align what we have here at UVA. And so I think when we have not only attendings and residents coming from different institutions, but therapists coming from different institutions, it's important to have one consolidated terminology that we use here at UVA. So that was the goal. We met and we sat down. We came up with an updated recommended terminology, and then we then distributed that via email, but also took that to their grand rounds. So I met with the therapy teams at their grand rounds and reviewed that before we sent out the second survey. So this was the updated recommended terminology. It was simplified to 5 terms: non-weight bearing, touchdown weight bearing, partial weight bearing, specifically at 50%, heel weight bearing, and then weight bearing as tolerated. So that's the range of the recommended terminology that we're going to use going forward, and hopefully have a better understanding with the therapy teams on what our patients should be following. And I've sent this out, so I don't think we need to talk through each one specifically here. But it also makes recommendations about assistive devices and how they can be used to help these patients. So the second survey was sent out, and essentially it was just a pop quiz on how well we did in educating all the teams and how much agreement we have now. So this first question was just to identify that people know we're no longer going to be using toe touch weight bearing. We did pretty well. 90% of respondents agreed that we're going to use those 5 terms. There still were people that wanted to use touchdown or felt that there are other terms we shouldn't use. I even received individual emails from therapists saying, I think you made a mistake. You left out touchdown from the recommended weight bearing. So it seems to be really, really ingrained and really hardwired in people's brains to use touchdown. So I think it highlights that we'll need to continue to educate. When describing non-weight bearing, we went from 92 to 100%, which is good. We now have 100% agreement on what non-weight bearing should mean, both in weight bearing and position of the foot and leg. When we use touchdown weight bearing, we now have 88% agreement on what the position of the foot should be and how much weight should be transmitted. When we looked at partial weight bearing, 98% of the respondents were correct in looking at the position and weight bearing. When we look at heel weight bearing, 92% are in agreement with the position and the weight bearing at that. And then when we look at weight bearing as tolerated, we now have 100% agreement on that. The feedback at the end of that survey was mostly just the therapists saying that they felt like this has been helpful and should help with their patient care. So I think to summarize, before we had too similar terms, we didn't have understanding within our department. So I think that led to confusion with the therapists and in turn confusion with the patients and was causing a lot of miscommunications between the teams. And so hopefully now we have more uniform terminology. We've improved our agreement on non-weight bearing touchdown and weight bearing as tolerated, as demonstrated by the survey. So I think that those are all good things. We did have attrition in the survey. We went from 89 respondents to 50, and there's not 100% agreement on all the terms. So I think it just highlights that we'll need to continue to educate, and I think that can be helpful with some dot phrases and continued education with the therapists.
So this is a retrospective evaluation of orthopedic team member injuries. So CDC estimates that hospital workers sustain about 385,000 sharps-related injuries annually. And such injuries both have a financial impact and as well can have an emotional impact. Some data suggests that residents that have a team member injury oftentimes can go through depression while taking certain medications or have certain limitations with their partners as a result of those things. But no one has previously looked at UVA orthopedic sharps events, why they occur, how they occur. And then we'll talk a little bit more about prior art when we get to the results. So the purpose of the study is to determine when these happen, how these happen, as mentioned before. And then we also wanted to look at the relative rates in different subspecialties. So this study examined all the BSafe data collected for orthopedics from July 2019 to 2022. In October, and 56 events occurred. And so these were defined as any Sharps injury that was due to a needle, a wire, a bone fragment, or saw, or anything else that could have penetrated the patient's gloves and skin. Types of team members were analyzed in the study, including medical students, residents, attendings, fellows. And then it also looked at whether it was at OPSU, main OR, and time of day, which I think is maybe the most pertinent new information that hasn't been looked at before. And so this was mostly to look at trends in these injuries. And so again, I think one of the more pertinent or newer information we can garner from this, many studies have shown before, I think they broke down during procedure a little bit more, but Sharps injuries are most commonly during suturing. And then other studies have shown during fragment fixation or injuries on K-wires as being second most common. But if you look at our injuries, although we don't have it broken down as to when during the procedure, the time of day I think is very interesting. So from time period about 1 o'clock to 3 o'clock, so after lunches, during shift changes, when there's a lot of transition in the OR, seem to be strongly correlated with the most Sharps injuries. Main hospital had more Sharps injuries than outpatient surgery center. So team member role. So residents, we did have more injuries than the attendings did. Have more on that data. And then also when you break it down to year, not much difference between year and training in terms of Sharps injuries, but certainly more residents than attendings. When you look at which department though, we'll go to the next slide, certainly is skewed by the number of OR hours per quarter. So if you look at how many injuries occur per 1,000 hours in the OR, it was a little bit different than when you look at the total number of Sharps injuries. So adult recon had many Sharps injuries, but also spent a lot of time in the OR. And so when you adjust for that, comes out. Oncology and pediatrics are a little bit skewed by the fact that they have much less OR time. So hard to sort out many differences there. Again, the most common time for these Sharps injuries coincided with OR staff shift changes and lunches at the latter portion of the elective day, which is a significant finding. And then again, consistent with prior literature and other institutions, a significant number of the events occurred during closure. And then again, residents sustained more injuries than attendings. And increased awareness to prevent TMI during the closure and at the end of the elective day is beneficial. So I think there, should be a focus kind of brought in at the end of the day, but it is certainly pertinent whenever we're having team switch, when the music's loud, a lot of distractions, people are getting ready to go home. Kind of refocusing the OR, I think, is important, regardless of what portion of the case you're in. But I think this highlights, that people do get a little bit more lax at those times of the day. And then while all subspecialties were at risk, may be helpful to look into why maybe certain groups have more than others. I know the pediatrics was skewed. There was maybe 2 injuries in a whole year, but their TMIs per 1,000 hours was high just as a result of low OR time. And that's all I've got.
Questions? So Alyssa, we at our surgical chairs meeting, and OR leadership, which is twice a month, we review this data. So the data that you presented is well known across the institution, and every discussion we have is that what's the root cause of it, and it's multifactorial every time because there's a different reason for every case that's delayed. So what do you think has to happen? There's a comment on, I can provide a comment because I know what needs to happen, but what do you think needs to happen to actually create a better on-time start on the weekends or even during the week?
So first, I think it's fine that's multifactorial, but I think that it's important to start addressing some of the factors. And so you can look at it in a short-term bucket and then a long-term bucket. In a short-term bucket, I mentioned this briefly, was just talking about elucidating the actual reasons for delays. So we can't solve a problem that we don't know what the problem is. And so one would be elucidating the actual reasons. I think in a more long-term bucket, if your goal truly is a 7:30 start, people respond to incentives. So it doesn't have to be monetary incentives, but incentives of being part of a team. So you get to go home when your team goes home, and people respond a lot better to that, like an OPSI. The entire staff goes home when their surgeon finishes. And so I think everybody being on the same page as to their common goals would be helpful. Because right now people have competing goals. You have a competing goal for somebody who leaves at 3 p.m. and just wants to bide the time until 3 p.m. hits, and then the goal of the surgeon who wants to efficiently get in and out of the operating room. So I think kind of breaking it into smaller subsets, and I don't know, at main hospitals, we love to have workforces and teams and cost analysis and stuff like that. But I think just dividing it into a short-term realistic goal and then looking at overarching longitudinal goals would be helpful in addressing, once again, a very difficult problem that every operating room struggles with.
I think it's also making clear expectations and holding people accountable. It's the number one thing to do, is saying OR start at 7:30, not 8 o'clock. And that's never been done by our OR leadership here on the weekends. So the expectation has to be made clear, and there's consequences when expectations are not met, whether it's performance evaluations, whether it's these individuals should not be in charge of the OR if they can't hold people accountable and make sure that these expectations are met. When you have a multifactorial situation, you have to define the expectations. You're not going to be able to solve every single problem every time. You just have to make the expectation clear.
So I would like to echo Dr. Hubbard comment. So I also thank you doing such a good quality study. So show me the data. This is the data. How can we change the practice? I would like to mention Memorial Day. My email, sorry, it's Memorial Day, okay? I just didn't sign up. Don't want to bother Dr. Hubbard or whatever leadership. So we're waiting. Dr. Rich on call anesthesiologist. We both checked in before 7 o'clock. 7:40, we're told we have only one transporter. We cannot get a patient in the operating. So Jesse went upstairs, pick up the patient. Senator, I said, Jesse, this is safe. I wanted to with Jesse. I wanted to upstairs. And I had just no size, no service on the holiday. So this is not acceptable. Like what Dr. Chabra says, somebody needed to be accountable. So I sent an email to myself. If you want to see, I can send to you now if you have the pleasure. So, and then this weekend, Father's Day, nobody works, send a patient. Judge has to go upstairs, bring patient down. This is how it works. As an attending, I feel like it's so frustrated. Why? This is about patient care, right? This is not a car shop. To repair cars, can delay, that's fine. But this is a human being. So somebody needed to be accountable. I think this study, Dr. Yabra, I would really thank you work with residents to work on this, important issues. And this can be published also. Thank you.
What is the average time patients call for a 7:30 case?
So that's the thing, actually, one of the exclusion criteria was that if the case was posted after midnight and put in a room after 4:30 in the morning, then I excluded it. I was at least giving them the benefit of the doubt. And so realistically, patients were called for, so they were put in the room typically at 4:30 when our overnight resident calls. It's just become our culture that our overnight resident calls at 4:30 and puts it in the room. And then from there, they were typically called for around 7, and they were in SAS on average at 7:15. But I know Dr. Cooper had an instance where they didn't have a rep, they didn't have a scrub. I mean, his first start case didn't start until 1 p.m. I actually threw that out because it would just skew the data too much, and I was trying to get a realistic average. But there are some kind of horrendous incidences of our own attendings that are just sitting around until 1 p.m. and it's not their lack of willingness to care for the patient, it's not the residents' lack of willingness to be there. So I think everybody's kind of in a state of frustration. So looking at kind of moving forward, this is kind of the little call to arms section, and then you move forward into some sort of meaningful progress from there.
Monica, I'm going to shift gears so we can all diffuse. My Congratulations on setting up a prospective study, identifying an intervention, potentially the outcome, but still early. But how did you standardize the measurements? Who made the measurements and the accuracy from one to the next?
Yeah, so we had both attendings and our research coordinator do them. So it was essentially the same group of people doing all of them. There were some measurements that were done just from me going through every single chart that were done by the attending and the research coordinator that were the same. So it was just the same group of people for all of the patients that we had doing.
I think you'll need to do some measure of how accurate that is from one person to the next.
Yes.
It's not the same person.
I agree. I think that would be helpful as well as the margin of error for the inclinometer itself.
Yeah.
So just to have a range, and then from there we can find a clinically important difference, so that when we have a bigger data set, we actually what's important on a patient level, not just numbers level.
The other thing would just be caution on how you present this as, well, maybe this is as good as physical therapy, because you're not looking at all potential outcomes and benefits of therapy, edema control, strength return, function, etc. You're looking at just one parameter, which is range of motion. So make sure you're focused on that. And just from being around for a while, insurance companies will throw out decades of data. There's one study that shows they can cut costs. And they could just say, oh, look, physical therapy is not necessary, ankle fracture, pylon fracture, fringe that idea if you're going to exclude therapy coverage. So you say, well, maybe somebody who can't get therapy, this at least does as good a job as therapy getting your dorsiflexion. So focus on just what you measure, but still congratulations on the study.
So just to piggyback on that, so I think, and you had in your, if I remember correctly, not just range of motion, you had some promise data and pain scores. So I think one of the things we know from particularly adult recon literature is that a statistically significant change in range of motion may not be a minimal clinical difference. And so it's also important to what Dr. Dudek speaks to is that first you got to make sure you know what you're measuring, but once you do, that in itself may not be sufficient to imply clinical difference. But I agree, these are the types of things that can really change practices. One question for Pearson. I might have missed it, but you said a couple of different times you used hours of 1,000 hours operating time. Did you normalize just the case? Because unless it's like a wound vac, every case has a closure, for example. So if you just normalize the number of cases, I assume you did that.
So this was, what do you mean?
You said the number of incidences of injuries based on 1,000-hour operating time, rather than normalizing to the number of hours of cases, just normalize it to the number of cases. So one 15-hour spine case is the same as one, 20-minute case because it's closure. It's just a single closure, a single surgical procedure, rather than normalizing to hours of cases.
I did not do a separate analysis looking at just closure time, but certainly I would think there would be risk. I would think there would be risk for a whole 15-hour spine case, even though it is one case as opposed to multiple cases.
It might be worthwhile. So not necessarily just closure time, like one pediatric case. If you normalize that 2 injuries to just the number of cases versus hours of operative hours, I'm maybe not understanding the data or I'm not expressing myself.
I think if I were to do that, it might overestimate, say, spine cases, TMIs, because if you had 1,000 hours might be much fewer cases than a joints case. And so I think that it might underestimate the risk of a spine case and overestimate the risk of other cases. I think there's still risk, when you're pulling bone fragments.
Yeah, absolutely. Okay, thank you.
Here's one thing you look at the needle count. They count the needles for every case, so that means correlation too.
Yeah. I'm not sure where to find that in Epic, but I could certainly track that down.
Hey, Liza, did you look at A1C as a measure of overall control versus just day of surgery glucose?
Yeah, so the hyperglycemia group, I think, had an average A1C of 9 something, and the control group was, 7 something, and it was statistically significant, the difference. And I think that makes sense. I mean, people who are going to have higher blood sugar levels are probably on average going to sit higher, but I do find that that's interesting that like the A1C level, if that's elevated, is still a predictor of increased complications, But if you just have, a day of surgery glucose of 250, that's not necessarily dooming you to something bad happening.
Is there a way to put that together? If you're gonna advise, let's say you had the ability to advise an anesthesiologist on your perceived risk as a surgeon. And that patient came in and they're 250 this morning, but their A1C is 7 versus 9. I mean, is there a way to put that together and say, well, my level of risk is I'm not worried about this, or I am worried about this?
Yeah, I mean, I would, if there was a patient who, A1C of say 7, but comes in day of surgery and has a 250 blood sugar, I would say, from my perspective, I think this patient is still low risk,
From your data, can you put that together?
Oh, yeah. Because we have, we still, like, you can see that the elevated A1C is still an increased risk for complication, but even those people who have high A1Cs, but also have high day of surgery blood glucose aren't at, or I guess I should say low A1C, but high day of surgery blood glucose don't have increased risk. Does that answer your question?
Yeah, I had the same question. So the A1C, like Dr. Rickon, you know that we have a clear cutoff level. So this is the patient, if you look at your data, if their A1C also high and their sugar level also high on the same day, and then if this group is going to be higher risk compared with your control group, that's going to be very valuable data.
Yeah.
So do you have that data at this point?
I didn't include it in the study, but we have the data available to include that in the analysis, like to make a table essentially with.
Right. Yeah, that'll be.
So that's really important for us. I would encourage you to do something else in addition, is to talk to the anesthesiologist and find out, because a lot of times they might be canceling for reasons unknown to us, that they find that anesthesia complications in recovery, extubation, or whatever are much higher. So I would proactively do that research too with them and talk to them and find out why it is that canceling. If it's just because they say routinely we just have a solid number, you can probably preempt a lot of things and also strengthen your study to understand why the anesthesiologist is cutting them.
Yeah, I think that's exactly what one of the next steps was. Yeah.
I'll add to that. So this study looks at procedures that really don't involve anesthesia.
Yeah.
So local anesthetic, they don't have any research that shows any changes in anesthetic complications with blood sugars. They also have the ability to control blood sugars. And they don't consistently. The other challenge is that a lot of these patients are told to be NPO the night before. Patients sometimes don't take their medication, which also lowers their blood sugar. Sometimes people get lows at night and then they take something to treat that, and then they show up to surgery and they're higher. So I think the idea that if you have a consistent number like an A1C, which is 7 is about 160 roughly. And so again, not an egregious number for people. But they show up that day and they're 250, that's not their history, right? And so they're canceling them based on a random event. And so we treated everything based on random events, and we obviously would never do surgery. And so I think the idea here is that looking at data more consistently, as it's been allocated here, is probably important.
I think it's great.
And it obviously depends on the anesthesiologist, because there are some that they chew gum, they cancel them. And so there's variability on who that individual is for that day, and they don't have a consistent pathway. So this is helpful to give them consistency potentially going forward.
I think that this is like a really ripe study to do a prospective analysis, like where you would actually kind of randomize, as these people come in, you could look at how moving forward, or I guess you could do like a time-based cohort study where you look at if you let people go forward, how did they do who have like a higher A1C. And so I think that like a lot of this retrospective stuff, you kind of miss some things in the weeds, whereas if we actually went forward and let those people have surgery and then analyzed them and then compared that to people who got canceled and looked at like the cost analysis, you could probably come up with something pretty good there.
I was going to say, I think if we could get our anesthesia friends on board with that, that would be great. Because we're like, currently I'm stuck in a catch-22 of like, it would be great to have more data with people who had higher blood sugars, but I don't really have that because people who did have those really high blood sugars got canceled. And so we couldn't include them in our analysis.
Yeah, exactly. And I think that, so long as patients are counseled on the risks and we tell them that this is something we're studying, that that can make a really big change, especially for these smaller procedures. And you could even like say, well, that we won't use anesthesia, we'll do it under, Vermont or something like that. And hand surgery has that ability, so.
Probably will have a hell of a time with the institutional review board getting something like that.
But we have a live study now.
Well, you have data that's considered data because you're collecting it after the fact.
Yeah.
If you're trying to enroll people
Yeah.
and we'll treat you, we won't treat you, boy, you're gonna have a hard time getting that study done.
Yeah.
So you have to be a little bit more creative